You're listening to
CRST,
a podcast
from Bryn Mawr Communications.
Welcome to the second episode of special four-part series of cataract refractive surgery today. The podcast that dives into ways in which you can differentiate your cataract and refractive surgery practice from others in your local market. I am Ahmed Assaf from Ain Shams University, Cairo, Egypt, your host for today. During the first episode, panelists shared their peers for planning cataract and refractive surgery. In this episode, I'm joined by Johnny Moore from Cathedral Eye Hospital in Ireland, Mayank Navanati from Brighton and Sussex University Hospitals in United Kingdom, Ivo Silva from Hospital CUF Tejo Lisbon in Portugal, and Yasha Windelstein from Institute Refractive and Ophthalmic Surgery in Switzerland. Our discussion today will focus on ways in which we can deliver a great experience to our patients during cataract and refractive surgery. I am excited to learn more from my colleagues today. So let's get started. As you know, ultrasound in cataract surgery is considered as double-edged sword, and we use ultrasound energy to emulsify nucleus during cataract surgery and lens-based refractive surgery as well. Yet at the same time, it may injure precious corneal endothelium as well as other delicate intraocular structures. So, fragmentation may help surgeons to reduce ultrasound energy inside the eye. And I'll start by asking the panelists, I want to ask you about the preferred fragmentation pattern. So, Dr. Navanati, would you like to comment on which way or which fragmentation pattern do you like, especially in cases of hard cataract?
Thank you, Dr. Assaf, for inviting me for this podcast, and thank you for this question. For the hard cataracts, I usually use a vertical chop technique after doing a deep sculpt in the center, and that works really well for me. Unless it's a leathery cataract where actually vertical chop needs to be at multi-level. So we go from front to the back and then make sure that the posterior plate of the cataract is separated with the second instrument.
Great. And so it's a kind of a stop and chop technique, or you start just quick chop from the very beginning?
It's a stop and chop technique.
Exactly. Okay. Dr. Ivo, would you like to comment on fragmentation pattern, especially in cases of weak zonules? Do you change your parameters? Do you change your technique for disassembly of the nucleus?
I would like to thank for the invitation for this podcast, Dr. Assaf. So I mostly do in the bag horizontal chopping. That's actually my go-to technique in any cataract, but especially in hard cataracts as well. I think it works really well as long as you have an appropriate chopper, a good cutting chopper that protects the capsule. So that's the technique I kind of specialized in, I would say. In weak zonules, we always learn when we're learning cataract surgery that in very dense and mature cataracts we probably should plan for an extracapsular or something like that. I kind of leaned away from that. I always try phaco, and even in weak zonules, I find that there's no harm in trying to do a big circular rhexis and try to phaco from a small incision. Because if you notice that during phaco, the zonules are actually very weak and you have a big phacodonesis, you can always change your strategy for that cataract. So the only thing I really change is I always have different options of IOLs, because I feel that probably there will not be a stable bag to implant a monofocal one-piece IOL in the bag. So I always have other IOLs planned. So I usually have a 3-piece and a iris fixated IOL in hand to be able to use them in case we need to. But in terms of phaco fragmentation patterns, I really don't change it at all.
We'll talk about the IOL later. So what about the pseudoexfoliation? You know that the cases with pseudoexfoliation have sort of complex cataract surgery. There is weak zonules as well as maybe the pupil is not pretty well dilated. So do you change the fragmentation pattern? My question is to Dr. Moore, or just do pseudoexfoliation as a routine cataract surgery?
Dr. Seth, thanks once again for inviting me to speak here. And to answer your question, no, I would go along the similar lines as Dr. Silva. I do a horizontal chop in the bag. For cases specific, like you say, I would tend to do a larger rhexis, and also prepare for things like with a CTR in these sort of cases, potentially to introduce at some point, even during the phacoemulsification if required. I think the really key point in doing these sort of chops, however, is to have really good suction, and therefore, so to have very high vacuum, but also to retain really good stability of the anterior chamber is key in these situations. And if you have high vacuum, you can really control that nucleus and allow yourself to chop. And sometimes, as I say, if there's a leathery aspect to it, you're able to lift it away from the posterior capsule and still to safely, maybe with one or two pulls to go through and know you're still you're not going to impact upon the posterior capsule in this. So I think to me those are the key things, and just to take your time and to ensure that you're getting through the nucleus fully, but to be able to hold it carefully.
Which chopping technique do you prefer in pseudoexfoliation with the small pupil, the horizontal chopping or vertical chopping technique?
Well, I sometimes do a combination, and really it's whatever is available. I mean, there's a case of feel here, and in a lot of these cases, you're feeling rather than seeing, so you know where the position is. As I say, based upon you're able to hold the nucleus, you're able to actually pull it slightly towards you, and you know you've got space behind that, and you know the depth that you can go to in these cases as well. So I don't change my routine too much here, but I again, we're into cases rather than seeing what you're doing, you're feeling what you're doing.
Okay, thank you. Dr. Windelstein, would you like to use other ancillary methods like the femtosecond laser or MyLoop in such complex cases like dense cataract or cases of weak zonules, or just do it as a routine phacoemulsification?
I started in a university clinic where we didn't use a femtosecond laser. We had one, but just learning it from other surgeons. I never used the femtosecond laser. We had the MyLoop available. We rarely used the MyLoop if it presented useful, like in very dense cataracts, just from seeing that. And there were some situations where it came in quite handy, especially for the more dense cataracts. Now in Zurich, I'm faced with a different situation, and we have a very high rate of femtosecond lasers. And I have to say that it does come in handy, especially for the rhexis, because it's just very safe. And I feel like in the more complex cases, especially if you're not facing decades of experience, it might be very nice to just have a secure capsulorhexis and don't run any risk of it running out. So I do like the femtosecond laser in weak zonules, for example. Just gives you a bit of more security during the surgery.
Great. So you'd like to you use the femtosecond laser mainly to secure the rhexis, and you can use the technology as well to fragment the nucleus and soften the nucleus to minimize the ultrasound energy. But in cases of premium lenses, as I understood from you, you prefer the femtosecond laser to secure the size as well as the location of the rhexis, right?
Yeah, that's basically it. So you have a very centered rhexis. You have the perfect diameter of the rhexis. So it's just a very nice scenario for me as a surgeon.
For me, I was fortunate to have both technologies. I can use the femtosecond laser as well as the MyLoop. And to be honest, I like the MyLoop, especially in hard cataract, because we can have a complete separation of the nucleus into two halves, and sometimes we can divide the nucleus into four quadrants. With the femtosecond laser, sometimes we cannot get a complete division or separation of the nucleus because we have around 400 microns offset from the posterior capsule. Otherwise, the femtosecond laser energy might accidentally hit the posterior capsule. So we have to be off around 400 microns, and we end up most of the times with the quadrants are still attached together posteriorly by a posterior isthmus. But with the MyLoop, we can divide the nucleus completely by the movement of the loop from periphery toward the center, so we can have a complete separation of the nucleus. So I prefer the MyLoop in brunescent hard cataract in order to divide the nucleus into two halves, and we can turn around and divide each half into two quadrants. Again, sometimes my experience with the femtosecond laser energy, sometimes because of the density of the cataract, the laser energy cannot penetrate deeper into the deep layers of the lens because of the opacity. So you end up with the just scratches on the superficial layers of the cataract, but there is no too much efficient separation or fragmentation in the deeper layer of the cataract. My question now to Dr. Silva: would you like to use the femtosecond laser in cataract surgery, especially in complex cases?
I've used it quite a lot for some time, in most cases, and lately I haven't been using it that much, except in patients that really ask for it, or in premium IOLs with very good dilation, and that's basically for two reasons. One is because with femto you always lose dilation, so if mydriasis is not really good, if you have like a medium-sized pupil, when you'll start surgery, it will be smaller. And especially in pseudo-exfoliation and weak zonules that Yasha was mentioning, I really don't like it at all. And it's just because of one thing, because when you do the rhexis, when you do the manual rhexis, you just get capsule. When you do the rhexis with the femto, it's very centered and regular, and it has all those benefits, but it goes all the way down into cortical material. So you not only have the capsule, but you have a cap of cortex. So when you do your hydrodissection, the plane you get is usually not between capsule and cortex, and you have to be very careful in making sure that your hydrodissection goes in between those parts. And if you're not careful enough, when you at the later stages of surgery, when you're trying to get to the cortical matter, it's more stuck to your capsule, and it will be easier to get a zonular disinsertion. I mean, that's my experience with femto. I really like it as a technology, and I do believe that it will probably see some use, and it's going to be important for younger surgeons for sure. But it has some issues that need to be sorted out, in my opinion.
Yes, I agree with you that to get the benefits of the femtosecond laser, you have to get a pretty dilated pupil. Otherwise, you are stuck with a small pupil, and then you will do some sort of small capsulotomy and makes the surgery even more complicated. And it's a new technique, so we have to modify our techniques compared to the routine phacoemulsification, because we don't do hydrodissection with the femtosecond lasers. That's why the cortex somehow might be sticky to the capsule. So we need to change our technique with the femtosecond laser, but we cannot deny the benefits of securing a perfect capsulotomy in terms of size, location as well. One can as well address some of the corneal astigmatism, especially if the astigmatism is less than 1 diopter. So we can nail this small amount of astigmatism to get the maximum benefit, especially in the cases of premium IOLs. But in terms of fragmentation, definitely the femtosecond laser can fragment the nuclear 3 and 4 nuclei, but in cases of brunescent cataract, I prefer the MyLoop, because with the MyLoop we can get a complete separation of the nucleus into two halves and sometimes into four quadrants. But with the femtosecond laser, we end up with a posterior isthmus connecting the quadrants together, because we are not allowed to go with the femtosecond laser energy pretty close to the posterior capsule. We have around 400 microns offset from the posterior capsule. Otherwise, the laser energy might hit the posterior capsule and complicate the surgery. And again, because of the opacity, sometimes the femtosecond laser cannot penetrate through deeper layers into the cataracts. That's why I personally prefer, in cases of Brownisian cataract, to minimize the ultrasound energy, to use the MyLoop in much better and much more efficient compared to the femtosecond laser energy. Now let's move to the fluidics. As you know, the phaco technology, including the fluidics, as fluidics play a crucial role in cataract surgery. And the paradigm now is shifted towards improving the anterior chamber stability during surgery with the new pump system. So my question to Dr. Silva, can you please share your experience with the Quattro pump technology?
Yes, sure. So last year I had the opportunity to work with the Quatera machine, with the Quattro pump technology, while we had it in our hospital for a brief period of time. And just for context, I did my training during residency with the Signature machine. Actually, I started with the Sovereign from AMO, now Johnson & Johnson, and then we moved to Signature. So I did my training with that. Then I moved hospitals and I started doing surgery with the Infinity from Alcon. Now we moved to the Centurion, and I also have some experience with the Stellaris machine. So I've worked with quite a few different machines and different pumps. And the Quattro pump, it uses a different technology to keep the anterior chamber stable, whereas the old machines had the bottle and it was like a height-controlled infusion. And the new ones, like the Centurion, have a plate system that compress the bag and that infuses the BSS into the eye. The Quattro pump has basically two pumps that work at the same time, one for infusion and the other one for aspiration, and they just compare the volume of liquid that goes in and outside of the eye, and it tries to maintain the IOP stable while doing that. So in my experience, it works pretty well. I mean, the chamber was very stable, and in terms of ultrasound deployment, it was also very efficient. But what was better for me was the fact that it was very easy. It was very user friendly. It was very easy to optimize, because having used several machines, in the end, they all work well as long as you have the time to optimize them to your liking, to the way you like to work. I can't really say that one is better than the other. I think they're all good as long as you have the time and you take the time to optimize them to your liking. What I really liked about the Quatera is that it was quite easy and fast after just a couple of cases to get it working in the way I like to do surgery. And that was really good for me.
Great. So, Dr. Moore, I think you have experience as well with the Quattro pump technology. Can you share your experience, please?
I used it in my clinic for several months, and in fact, it was just taken away to be sort of serviced again, and it's back again. So I'll be reusing it again. But yeah, I would concur with what Dr. Silva said, that it's very easy to get it working. To really, and the rep was there. You basically say, look, I want this. I mean, I like high flow and a lot of vacuum, and really they were able to adapt it really quickly. And I think the key thing is that it keeps a very stable anterior chamber. There's no doubt about that. You can push this hard without getting surges and loss of the anterior chamber, which is always the worry. For all of us, that different times you're losing that anterior chamber. So, I mean, this worked very well. It was very straightforward. It didn't pose any problems, and it didn't. You weren't getting a lot of anything unexpected with it, which was the nice thing. It sort of delivered what it said in the tin. That it'll give you stability and ease of surgery.
Great. So, can anyone share experience with different pump systems, not especially to be a quattro pump, like let's say peristaltic or Venturi pump, especially in challenging cases? So, Nabanati, what kind of pump do you prefer in your routine and challenging cases?
In challenging cases, I would prefer peristaltic pump because I like slow motion phacoemulsification with soft shell technique. So I find Venturi pump to be slightly faster, and I don't mind using Venturi pump in routine cases. I've got access to Centurium, Constellation, and Stellaris. Based on which hospital I'm doing the case, I'll have access to these cases. But routinely, if the case is complex, I would prefer peristaltic pump.
So, what about the ultrasound? What kind of ultrasound modality do you prefer? The longitudinal, the transversal, or the torsional? This is the question for Dr. Nabanati as well.
I would normally prefer the torsional phaco because in complex dense cataract cases, it would deliver less energy than conventional coaxial phacoemulsification. So that's my preferred.
And do you combine sometimes the torsional with the longitudinal, especially in hard cases?
Yeah, yeah. Depending on the density of the cataract, I would then increase the longitudinal power based on the cataract density. I would prefer to use only torsional if possible, but if I have to increase the longitudinal at the same time, I'll do that.
Dr. Silva, would you like to comment on the ultrasound technology you use?
I agree with Dr. Nanavati. I tend to prefer torsional, and if I can do the case with just torsional, that's what I'll do. Sometimes you need to change to longitudinal, but you increase shattering. So it's kind of a trade-off. So every time I manage to do it with torsional, I do it with torsional alone.
Okay, great. Dr. Moore, which is better for you, the fast phaco or the safe phaco?
Fast phaco or safe phaco. Well, I always think you want to do safe phaco. Whether it's fast or not, it should be safe, you know. So I think the correct answer is always to go for safe, irrespective of speed, you know.
I see. Okay, and Yasha, do you prefer the fast or safe phaco? Because you are doing a femtosecond laser and sometimes it's somehow time consuming. So would you prefer the safe phaco or the fast phaco?
I think it's definitely the safe phaco, which is way above the fast phaco.
Okay. Okay, I think if you can combine both, it would be marvelous. So we can get the safe as well as fast phaco, because by fast phaco we can reduce the injury, the time of injury of the ocular structures. So I think this is related somehow to the fast visual recovery as well. So anyhow, but of course safety comes first. Now let's move on the IOL selection. As you know, in the current era, we are privileged by having many options of IOLs like the monofocal plus, new generations of EDOF lenses and trifocals. And now we can select the IOL to suit our patient's lifestyle and as well as according to the eye anatomy. So for example, the influence or the impact of the pupil size on the IOL selection. Dr. Yasha, would you like to comment on this? Does the pupil size affect your IOL selection?
It does, yeah. So if we are talking about basically, or for example, if we're talking about premium IOLs, multifocal IOLs, I think the size of the pupil is very, very important. So if the pupil is too big, nearing the 7 millimeters, I think it's always worth to think twice if you're going into the multifocal or EDOF direction. The plus in photic phenomena has to be very, very well considered for the patient, and if it's really his wish. If he stays with that wish, you might either consider convincing him of something else, or maybe going for a duet implantation where it's very reversible instead of just inserting a multifocal IOL in the back. I think that's one aspect. And if the pupil is too small, if I have something, it's very seldom, but if I have a pupil anywhere nearing the 2 millimeter zone, I might consider my multifocal IOL a factor of cost that's not giving the benefits it would give a patient that could make use of all the diffractive and refractive elements of the IOL. So those are basically two things I'd consider. Then a further factor is basically patients after LVC, where you can see the optical zone, and we have to compare the pupil size and the optical zone in order to make a decision for the IOL you choose. So yeah, I think pupil size, especially mesopic pupil size, it's a thing that should definitely be considered if you're choosing your IOL.
How do you measure the pupil size? Which platform or which device do you use?
We have the MS39, which does our pupil size measurement.
Okay. So does the angle kappa is considered in the IOL selection? And my question to Dr. Navanati.
Angle kappa is an important parameter. I do consider that when I'm using multifocal lenses. Sometimes angle kappa leads to decentration based on the visual axis and the amount of the angle, and that can actually be beneficial with certain types of EDOF lenses, because that will induce an additional comma, which is what we found in one of our studies. So if you have some decentration of these lenses, which has more spherical aberration in the center of the optic, it can induce a bit of comma, which helps reading more in these patients. But when it comes to multifocal lenses with rings or diffractive trifocal lens, angle kappa can be a bit daunting because it can induce a lot of dysphotopsia, which can then be a problem for the patient.
Okay, perfect. So does any one of the panelists do mix and match with the premium lenses?
I do indeed. So there are basically two occurrences where I do mix and match. One thing are patients that do not really want to go into multifocal IOLs because of the photic phenomena, but want just a bit more of depth of field. So a very nice thing for these patients can be doing a monofocal IOL in the dominant eye and combining it with a EDOF IOL in the non-dominant eye. I think that's also a very nice scenario for patients that already have one monofocal IOL from a past one-sided surgery. I've collected some nice data on that, and I'm about to publish that. On the other hand side, it's patient where one eye looks perfectly fine for a multifocal IOL and the other eye is, let's say, looking fine for an EDOF IOL. So I like to combine two IOLs of the same platform, let's say the Lisa tree and the Lara IOL, for example. So the perfect eye gets the Lisa tree, and the eye where there's maybe a little bit of irregular astigmatism that's not too high, let's say around a diopter or something like that, where I'm not very comfortable with toric correction. I might go for an EDOF IOL in that case on the second eye, and I've also seen very good results for that.
Okay, the same question for you, Dr. Windelstein. Do you do the micro monovision? Do you believe in micro monovision sometimes, or just go for the premium lenses in all your cases?
I do micro monovision as well. I do that in patients where I don't feel comfortable with multifocal IOLs. Let's say there's some singular drusens or anything else I'm not very liking. Let's maybe the personality of the patient or anything in that regard. Then I might switch over to a monovision scenario or mini monovision scenario. But I'm testing that with contact lenses usually beforehand and see if the patient is able to cope with the monovision scenario.
Okay, Dr. Moore, I think you have a lot of experience with the trifocal lens. Can you share your long-term data with the trifocal lenses?
Yeah, well, I suppose most of my experience with the or the latter experience is mix and matching with the Lara and the Lisa rather than bilateral trifocal. I mean, I started off with a small cohort of maybe 35 to 40 bilateral lenses. But my issue with really any of the bilateral trifocals is that you have to counsel your patients, and you have to be more careful with your patients, in the sense of ensuring that they understand there's an adaptation period, uh, to to get sort of good vision. So, and I just don't like this concept that you're giving someone a treatment and you're saying don't judge your vision for about 6 weeks. So I moved really to doing Lara Lisas, and I think the whole, if you look at the combined defocus curves of them, they're very good. Um, they're complementary, in the sense that, in that, for that computer distance, you really get an increased depth of focus there by adding the Lara into the Lisa, with the Lisa, and you get, for want of a better term, a wow effect. I mean, I tend to do the Lara first and then the Lisa a week later, and do any small adjustments on biometry based on the results of the Lara for the Lisa, and that way you get both accurate biometry results in your second eye, and you also get a seamless sort of adjustment to the multifocality of the incoming trifocal a week later. It really seems to prepare the way for it in the brain, having that small amount of multifocality initially in the Lara. So that's kind of been my go-to concept. Now I also take on board these aspects of, if you have a little bit of irregularity in one eye, you might go for the Lara in that, be it the dominant or the non-dominant, and I agree with that. And sometimes I just go for bilateral Laras if I'm a wee bit worried about irregular astigmatism, or sometimes in post laser cases. But that in normal eyes, who want to get out of glasses, I'll go to that Lara Lisa. When I sort of assess over a longer term the results, I in those cases I have about 86% or 100% independent from glasses, with that mixture. I mean, it's not 100%, but I mean the vast majority of those other 14% are independent for glasses most of the time, and it's really only the very close work that they're requiring additional glasses for.
Okay, my question to the panelists: does anyone implant trifocal lens in an eye with previous laser vision correction?
Yeah, I routinely offer this option to the patient based on their visual demands, because the formulas have changed and they've improved a lot. So most of the times, I would say that to the patient that it's 90% accurate in getting what we want to achieve, and 5% chances that I may have to do a top-up laser eventually. And I'll only offer these options to the patient whose corneas are eligible for a top-up afterwards. So if the cornea has got ectasia to start with following LASIK or some sort of laser procedure, then I'll warn the patient that I may not be able to top you up if we don't achieve the target. So based on the case selection, I would offer the option.
Okay, Dr. Silva, would you like to add something?
I don't do a lot of mix and match. I do in my routine cases, in my routine cataract cases, I do a lot of monofocal plus with micro monovision. I've been doing that with very good results, especially with small pupils. Going back to the pupil size question in the beginning, those patients really tend to get good results at near, even with monofocals. So I don't go with trifocals with those patients. But in cases where I'm really looking for spectacle independence, and in patients that come to us for that, I do think that the trifocals and that the mix and match strategy that you were both talking about is a very good idea. Also, doing the mini monovision or monovision in the patients that tolerate it with EDOF lenses, I really like those too. So yeah.
How much myopia do you target in the non-dominant eye in cases of mini monovision?
In cases of micro monovision, where I don't even do a contact lens trial, where I just talk to the patients about it, I do the dominant eye first, and I target it for plano or minus 0.25 and see how they do with their near vision. And then using that information, I target minus 0.5 to minus 0.75. That's what I go to with micro. If we have a patient that's previously myopic and that is used to using contacts and is actually has been using monovision in his life, I try to use that to his advantage and reproduce it after surgery. And if a patient wants more and is used to more, especially if he's myopic, I do a contact lens trial to see if they tolerate a larger difference than that. But you really want the curves to overlap, because if they don't, the complaints might be bigger.
Okay, thank you. Dr. Windelstein, would you implant a trifocal lens in an eye with previous hyperopic or myopic LASIK or laser vision correction in general?
I would do so, but it depends very much on the cornea of the eye. So as I said, it depends on the laser profile that was used for that eye, on the optic zone that was used. And I'm looking at the pupil. Then spherical aberration is a very, very important point for me. If I see that the spherical aberration is too high, I stray away from using multifocal IOLs in that eye. If I see too many irregularities in the optical zone, I also stay away from multifocal IOLs. So basically, if I'm having a centrally regular cornea with a good aberration profile, I think doing a multifocal IOL is fine, as long as the patient knows that the study results regarding my refractive accuracy are a bit lower than a normal patient, and it's okay to go with that. I think it's fine to do so. But as soon as something looks too irregular, I would stay away from it.
Okay, and my question to the panelists, what is the EDOF lenses? What do you think about the EDOF lenses, for example, in these cases, in this scenario? Suppose that you have a patient that is truly enthusiastic for spectacle independence, and this patient has done in the past laser vision correction in both eyes, and you see that the corneal aberration, like the Dr. Windelstein mentioned, that it's somehow high or there is some coma on the corneal surface, and still the patient wants somehow spectacle independence. Would you opt for EDOF lenses or just forget about these premium lenses and go for monofocal lenses? So let's start by Dr. Moore. What do you think about this case?
Once again, we go back to this assessment of your corneal surface, and I mean, I find the MS39 a very good tool in this case. It's accurate and it's easy to assess, both for a physiological pupil as well as just your standard 6 millimeters. So whatever the patient's pupil is roughly, and I'll assess the spherical aberration there. So if they had a previous hyperopic laser treatment and maybe have a lot of negative spherical aberration, I certainly don't want to go for an EDOF, which is utilizing positive spherical aberration, because you're basically just fighting one against the other. But in those cases, I would use a monofocal lens with either a zero spherical aberration or even a negative spherical aberration, just to add on there, and then utilize the two to trying to obviously remain within a non-toxic level of either negative or positive spherical aberration. And if they've had a previous myopic laser treatment, I mean, a lot of these, certainly in the larger ones, will have some degree of positive spherical aberration, and you can use those and combine them with I use the Rayner EMV in these cases sometimes to help me, or just a monofocal depending on the level of it. So it's really important that the assessment and the individualization of what you do based upon your corneal profiles.
Yes, because we have a lot of IOL choices, and I think we have to find which IOL is suitable for our patients based on aberrations, based on dry eye. Let's not forget the dry eye after laser vision correction, and of course the ablation profile, centration, etc. Dr. Nanavati, would you like to comment? Would you use the EDOF lenses in some cases of after laser vision correction?
Yes, I do actually, based on the patient's choice again. So it is based on the diagnostics, and mainly the diagnostics is Pentacam, iTrace, and OptiView epithelial mapping, which are there in my clinic. From a study which we've done for the ESCRS, called as a Mirov study, we found that smaller pupil size and almost zero spherical abrasion gives a bit of pseudo accommodation in patients, along with a slightly myopic in the range of minus zero point 0.3 diopters of spherical equivalent post-operatively. So then I will choose the lens based on the peripheral asphericity. So, for example, if the cornea is positively spherically abraded, then I'll like to have the total spherical abrasion to zero. So I'll use a lens which corrects the spherical abrasion to the maximum. Some of the lenses are neutral to the spherical abrasion. So based on the neutrality or the correction facility of the lens, I'll choose the EDOF lens.
Perfect. Dr. Yasha, what is your threshold for correction of astigmatism beyond which you opt for toric IOLs? So what is your threshold for corneal cylinder to do the toric lens?
I think a very interesting point that was brought up by you with the fragmentation question is the case of weak zonules. So I think it might be interesting not to use toric IOLs in an unstable situation, but rather go for arcuate incisions. I'd opt to correct around 125 to 1.5 diopters of cylinder. Otherwise, for toric IOLs, same as for arcuate incisions. As soon as I see for normal IOLs, something around 1.25 to 1.5, that's the point where I start with astigmatism correction. And if I go into more specific scenarios, let's say multifocal IOLs or EDOF IOLs, I'd rather be able to correct more for multifocal IOLs. So I think the threshold is somewhere around 0.75 diopters for my multifocal IOLs. And for EDOF IOLs, they're not as many studies on it as there for multifocal IOLs, but I'd correct also if I can from 0.75, but I'd set my my limits a bit higher, and I could also do an EDOF IOL around 1.0 diopters of astigmatism.
Yes.
A very interesting aspect I have here in Zurich is that we often opt for some kind of bioptic scenario where we opt for a rather spherical IOL and just plan a laser ablation for toric enhancement, so to speak, or for astigmatism enhancement afterwards. That was a very new scenario for me, and a very interesting one, because basically you correct two things at once. It's the prediction error and the cylinder afterwards, so it gives you a nice option in certain cases of multifocal IOLs where you can address both, especially for very short eyes, which are harder to calculate, or also even longer eyes that are a bit harder to calculate, and where you know that your chance of prediction are a bit higher than in normal eyes.
Interesting. How long do you wait after the cataract surgery until you bring the patient back to the laser vision correction to correct the ametropia?
Depends a bit. So if I plan for bioptics from the get-go, it's around 1 to 3 months. Personally, I'm opting to wait a bit longer to the 3 months mark, but sometimes you have patients which just want their adjustment a bit earlier and want it around the 1 month mark. If I am strictly speaking of just correcting something that's left that wasn't planned to go to the laser, I'd rather opt for the 3 month scenario, because I find that patients might, in some scenarios, patients might be a bit more content with their visual acuity after 3 months than they are after 1 month, and I think that's the nicer limit, so to say.
Okay, thank you. Now, question to Dr. Silva. What kind of alignment method do you prefer in cases of toric IOLs?
Digital. We use the Callisto system with the Zeiss Forum in the microscope. That's my go-to method.
Yes, I like it very much because it's linked as well to the IOL Master 700.
Yeah, exactly. You can get all the information from the patient. That's it's really good. The fact that you can have also the biometry and the IOL selection in the same place, you can get all the information. It's right there to you. So that's also a very important point for me.
So, does any of the panelists like to add something?
I think a nice point for the planning of toric IOLs is that you can also use mean vector calculation. So basically, if you have two devices available, let's say an IOL Master 700 and a Casia 2 or MS39, I think some studies, especially by Hoffman et al., have shown that mean vector calculation does result in some very nice results for a toric IOL planning.
Thank you very much. I think we have reached the conclusion of our session. What a great discussion we had today. We covered a lot of points in this episode, all of which are helpful in the quest to create a truly elevated patient experience. I would like to thank our panelists for joining me today. Now stay tuned for the third episode in this series, which will focus on a very exciting topic, which is lenticule extraction. Thank you very much.